Lewis's Medical Surgical Nursing, 11th edition, Chapter 18, Intraoperative Care. Historically, surgery took place in the traditional environment of the hospital operating room, OR. Now many surgical procedures are done as ambulatory surgery, outpatient surgery. In addition, the use of minimally invasive surgery, MIS, is rapidly increasing. More procedures use endoscopes, robotics, and other advanced technologies that lead to a decreased blood loss, incision size, pain, recovery time, and hospital length of stay. Hybrid ORs, which allow for MIS, such as endovascular procedures, and the traditional open incision approach within the same room, are becoming more common. This chapter discusses the basics of intraoperative care that apply to all surgical patients, regardless of where or how the surgery is done. Physical environment of the operating room. Department layout. The surgery department is a controlled environment designed to minimize the spread of pathogens and allow a smooth flow of patients, staff, and equipment needed to give safe surgical patient care. The department is divided into 3 distinct zones: 1 unrestricted, 2 semi-restricted, and 3 restricted. The unrestricted zone is where people in street clothes interact with those in scrub attire. These areas typically include the points of entry for patients, e.g. holding area, staff, e.g. locker rooms, and information, e.g. nursing station or control desk. The semi-restricted zone includes the surrounding support areas and corridors. Only authorized staff are allowed access to semi-restricted areas. All staff in the semi-restricted areas should wear clean surgical attire. This includes scrub attire that was laundered in an accredited laundry facility, long-sleeve jacket, shoes dedicated for surgery use or shoe covers, surgical head cover and mask that covers all head and facial hair, and any appropriate personal protective equipment, e.g. face shield. The restricted zone is found within the semi-restricted area. It includes the surgical suite, OR, where the invasive procedure takes place, and the sterile core. Masks should be worn and traffic minimized whenever sterile supplies are open in the restricted area. The physical layout is designed to reduce cross-contamination. The flow of clean and sterile supplies and equipment is separate from contaminated supplies, equipment, and waste by space, time, and traffic patterns. Staff members move supplies from clean areas, such as the sterile core, through the OR for surgery, and onto the instrument decontamination and sterilization area, e.g. Central Processing Department, CPD. Holding area. The holding area, often called the preoperative holding area, is an unrestricted zone where patient identification and assessment takes place. The size can range from a large centralized area that handles many patients to a small designated area right outside the OR. In some settings, a holding area is called the Admission, Observation, and Discharge AOD unit. An AOD unit is designed to allow early morning admission for outpatient surgery, same-day admission, and inpatient holding before surgery. The patient is identified and assessed before and after surgery, before being discharged home or transferred to an inpatient room. The AOD unit is important in outpatient surgery and prevents unnecessary overnight stays in the inpatient setting. Operating room. The traditional OR is a unique setting separate from other clinical units. This restricted zone is controlled geographically, environmentally, and aseptically. It is best to have the OR next to the post-anesthesia care unit, PACU, and the surgical intensive care unit. This allows for quick transport of the patient after surgery and in close proximity to anesthesia staff if complications occur. We use several methods to prevent the transmission of infections in the OR. Filters and controlled airflow in the ventilating systems provide dust control. Positive air pressure in the rooms provides air from entering the OR from the halls and corridors. ORs are kept within a narrow range of temperature and humidity to prevent bacteria growth. ORs follow strict protocols for cleaning between cases and terminal cleaning at the end of the day. The use of ultraviolet lighting reduces the number of microorganisms in the air. Using OR furniture that is adjustable, easy to clean, and easy to move promotes safety and comfort. All equipment is checked frequently to ensure proper functioning and electrical safety. The lighting is designed to give a low to high intensity range for a precise view of the surgical site. A communication system offers a way to deliver routine and emergency messages. Surgical team. Registered nurse. The perioperative nurse is a registered nurse, RN, who collaborates with the rest of the surgical team and implements the patient's plan of care during perioperative period. Depending on the size of the OR department, this role may include 3 domains: 1. Perioperative RN, 2. ORRN, and 3. PACU-RN. As an ORRN, you are the patient's advocate during surgery. This includes 1. Maintaining the patient's safety, dignity, and confidentiality. 2. Communicating with the patient, the surgical team, and other departments, e.g. CPD, PACU, laboratory. And 3. Providing nursing care discussed in the nursing management section of this chapter. During surgery, the ORRN assumes functions that involve either sterile or unsterile activities. The scrub nurse, sterile, follows the designated surgical hand, antisepsis, and glove and gown sterile attire, and prepares and manages the sterile field and instrumentation. The circulating nurse stays in the unsterile field, facilitates the progress of the procedure, and keeps documentation. Examples of nursing activities that occur during each phase of the surgical experience are outlined in Table 18.2. After meeting specific criteria, e.g. 2 years of experience, perioperative RNs can obtain OR certification, CNOR. CNOR certification is an objective measure, written test, that validates a nurse has essential knowledge and skills in perioperative nursing. Licensed Practical Vocational Nurse and Surgical Technologist. Depending on the state's Nurse Practice Act, an LPN, VN, or a surgical technologist may fill the role of the circulating or scrub nurse. Surgical technologists attend an associate degree program or a vocational hospital or a military training program. The Association of Surgical Technologists sets the standards for education, provides continuing education opportunities, and offers certification for surgical technologists. If the circulating nurse is not an RN, the LPN, VN, or surgical technologist must always have access to an RN. As an ORRN, you take on responsibility for supervising an LPN or VN or surgical technologist performing delegated nursing tasks. Surgeon and assistant. The surgeon is the physician who does the surgical procedure. The surgeon is primarily responsible for preoperative medical history and physical assessment, directing preoperative testing, and postoperative management, obtaining informed consent, leading the surgical team and directing the course of a procedure. The surgeon's assistant can be another physician, registered nurse first assistant, RNFA, physician's assistant, surgical resident or fellow, medical student, or a certified surgical first assistant. The assistant usually holds retractors to expose surgical areas and helps with hemostasis and suturing. In some agencies, especially in educational settings, the assistant may perform some portions of the surgery under the surgeon's direct supervision. Registered Nurse First Assistant. The Registered Nurse First Assistant, RNFA, works with the surgeon to achieve an optimal surgical outcome for the patient. The Association of Perioperative Registered Nurses, AORN, states that you must have formal education for this role and work collaboratively with the surgeon, patient, and surgical team. CNOR nurses or nurse practitioners can complete RNFA program to assume this expanded role. RNFAs can obtain certification. See RNFA. Anesthesia care provider. Anesthesiology is a medical specialty that focuses on clinical management of the patient in the perioperative period, pain management, critical care, trauma, airway management, and cardiopulmonary resuscitation. The anesthesia care provider, ACP, is the person responsible for administering anesthetic agents and managing vital life functions, e.g., breathing, BP, during the perioperative period. This can be an anesthesiologist, nurse anesthetist, or anesthesiologist assistant. A nurse anesthetist is a master's or doctorate prepared RN who has graduated from an accredited nurse anesthesia program and completed a national certification examination to become a certified registered nurse anesthetist, CRNA. The CRNA scope of practice includes performing and documenting a pre-anesthetic assessment and evaluation, developing and implementing a plan for delivering anesthesia, choosing, obtaining, and administering anesthesia, adjuvant drugs, and fluids, choosing, applying, and inserting appropriate monitoring devices, managing a patient's airway and pulmonary status, managing emergence and recovery from anesthesia, releasing or discharging patients from a PACU, ordering, starting, or modifying pain relief therapy, responding to emergency situations by providing airway management. An AA is a master's prepared health professional who serves under the direction of an anesthesiologist. AAs have completed an accredited program and passed a national certification exam. They take part in all types of anesthesia. This includes giving drugs, obtaining vascular access, applying and interpreting monitors, maintaining airways, and helping with preoperative assessment. Nursing management, patient before surgery. The preoperative assessment of the surgical patient provides baseline data for intraoperative and postoperative care and is used to plan intraoperative care. Preoperative care of the patient is discussed in Chapter 17. Provide physical and emotional comfort for the patient and caregivers, along with teaching about the upcoming surgery. This is particularly important in the same-day surgery settings, where caregivers must assume greater responsibility for postoperative care. Psychosocial assessment. Knowing about the activities that occur when a patient moves into the OR allows you to provide teaching and comfort, especially to the anxious patient. You can usually answer general questions about surgery and anesthesia, such as, when will I go to sleep? Who will be in the room? When will my surgeon arrive? How much of my body will be exposed? Will I be cold? When will I wake up? Refer specific questions about the details of the surgery and anesthesia to the surgeon or ACP. For patients who do not speak English, use a qualified interpreter. Separation from caregivers just before surgery can produce anxiety for the patient. Allowing the caregiver to wait with the patient in the holding area until they transfer the patient to the OR can reduce anxiety. Physical assessment. Perform a thorough physical assessment during the preoperative preparation of the patient. Chart review. Required chart data varies with agencies, patient conditions, and surgical procedures. Tables 17.2 and 17.4 provide examples of data we obtain during the preoperative assessment. This information gives an understanding of the past and present medical history and an opportunity to anticipate and prepare for potential needs during surgery, such as obtaining equipment or drugs. You can discuss any abnormal findings or concerns for infection and other complications with the surgeon or ACP. Admitting the patient. Agency policy guides the protocol you follow when admitting the patient to the holding area and OR. A general routine includes initial greeting, proper identification, and offer of human contact and warmth. The admitting process continues with reassessment of the patient and time for last-minute questions. Determine if any other tasks need to be done. Complete the chart review for the previously mentioned data and note any problems or changes. Ask the patient about valuables, prostheses, and last intake of food and fluid. Confirm that any ordered preoperative drugs were given. Provide a pillow or adjust the patient's position if requested. Most agencies require the patient's hair to be covered just before transfer to the OR suite to reduce potential shedding. You may offer complementary and alternative therapies such as aromatherapy, music therapy, guided imagery, and distraction. These therapies may decrease anxiety, promote relaxation, and reduce pain. Some agencies start these therapies before the patient is admitted to the OR. In others, such as ambulatory settings, they may start after the patient arrives in the holding area. Nursing management. Patient during surgery. Patient care in the surgical setting is dynamic and depends on the knowledge, skills, and judgment of the RN. The circulating nurse is responsible for implementing the intraoperative plan of care and serving as the patient's advocate. The circulating nurse focuses on the whole patient. This involves ongoing assessment, reassessment, and adjusting the care plan to promote the best surgical outcomes. Room preparation. Before transferring the patient into the OR, prepare the room to ensure privacy, prevention of infection, and safety. Individualized preparation is essential to achieve the expected patient outcomes. When a patient is severely obese, extra staff and special equipment may be needed to safely position and transfer the patient to and from the OR bed. During surgery, special equipment, e.g. extra long instrumentation, bariatric OR bed, may be used. All people entering the OR wear surgical attire. All electrical and mechanical equipment is checked for proper functioning. Each surgical item is opened and placed on the instrument table using aseptic technique. Sponges, needles, instruments, and small medical devices, e.g. surgical clip cartridges, universal adapters, are counted according to strict processes to ensure accurate retrieval at the end of the procedure. Any retained surgical supplies, devices, or instruments are sentinel events. Never events, or serious reportable events, SREs, that can result in negative outcomes for the patient. Sentinel events and SREs are discussed in Chapter 1. During room preparation and the surgical procedure, the scrub person does surgical hand antisepsis, dons sterile gown and gloves, and touches only items in the sterile field. The circulating nurse stays in the unsterile field and does those activities that involve contact with all unsterile items and the patient. This coordinated effort allows for smooth functioning throughout the procedure. Transferring patient. The patient is moved into the OR after the preoperative assessment is complete and the surgical suite is ready. Always maintain privacy during transfers through public areas by covering the patient with a gown and/or blanket. Each time a patient is transferred between beds, the wheels of each must be locked. Enough staff members using ergonomic tools for safe patient handling and movement should be available to lift, guide, and prevent accidental falling or injury to staff and the patient. Once the patient is on the OR bed, ensure that there is always someone on both sides of the patient until a safety strap is secured to prevent falls. The monitor leads, e.g. ECG leads, BP cuff, and pulse oximeter are usually applied after the patient is safe on the OR bed. Scrubbing, gowning, and gloving. Surgical hand antisepsis is required of all sterile members of the surgical team, scrub nurse, surgeon, assistant. When wet scrubbing is the chosen method for surgical hand antisepsis, your fingernails are cleaned first, followed by scrubbing each plane of individual fingers, palms, and forearms in the distal to proximal fashion. The hands should always be held away from surgical attire and higher than the elbows. This prevents contamination from clothing or detergent suds and water from draining from the unclean area above the elbows to the clean and previously scrubbed areas of the hands and fingers. Waterless alcohol-based agents are replacing soap and water in many agencies. When using an alcohol-based surgical hand scrub product, pre-wash hands and forearms with soap and dry completely before applying the alcohol-based product. After applying the alcohol-based product, rub hands and forearms thoroughly until dry before donning sterile attire. Once surgical hand antisepsis is completed, the team members enter the OR and put on sterile gowns and 2 pairs of gloves. This protects patients and themselves from the transmission of microorganisms. Because the gowns and gloves are sterile, those who have scrubbed can manipulate and organize all sterile items for use during the procedure. Basic aseptic technique. Aseptic technique is practiced in the OR to prevent infection. This is done through the creation and maintenance of a sterile field. The center of the sterile field is the site of the surgical incision. Items used in the sterile field, including surgical instruments and equipment, have been sterilized by appropriate sterilization methods. Team members must understand specific principles to practice aseptic technique. If these principles are not followed, the patient's safety is compromised and the risk for infection is increased. The surgical team is also responsible for following the guidelines established by the U.S. Occupational Safety and Health Administration, OSHA, and the AORN to protect the patient and the team from exposure to bloodborne pathogens. These guidelines emphasize 1. Standard and transmission-based precautions, 2. Engineering and workplace controls, and 3. The use of personal protective equipment such as gloves, gowns, caps, face shields, masks, and protective eyewear. This is especially important in the OR because of the high potential for exposure to bloodborne pathogens. Assisting anesthesia care provider. While you check the OR to complete the final preparations, the ACP prepares the patient for receiving anesthesia. You need to understand the effects of the anesthetic agents and know the location of all emergency drugs and equipment. If you are the circulating nurse, you may be involved in placing monitoring devices used during the procedure, e.g. ECG leads. If the patient is having general anesthesia, stay at the patient's side to ensure safety and aid the ACP. These responsibilities may include measuring BP and helping maintain the patient's airway. During the procedure, you are a vital communication link for the ACP to other departments, such as the laboratory or blood bank. Positioning patient. The surgical team carefully plans the patient's positioning and monitors the patient throughout the procedure. Positioning is a critical part of every procedure and usually follows induction of anesthesia. The ACP says when to begin positioning. The patient's position should allow for accessibility to the operative site, administering and monitoring of anesthetic agents, and maintaining the patient's airway. We use a variety of surgical positions, including supine, prone, lateral, lithotomy, or sitting. The supine is the most common position. It allows operating on most body systems, including the abdomen, heart, chest, or head. The prone position is often used in spine surgery, e.g. laminectomy. The lithotomy position is used for various gynecological, genitourinary, and colon procedures. With any position, take great care to prevent injury to the patient. Take care to 1. Provide correct musculoskeletal alignment, 2. Prevent undue pressure on nerves, skin over bony prominences, earlobes, and eyes, 3. Provide for adequate thoracic excursion, 4. Prevent occlusion of arteries and veins, 5. Provide modesty and exposure, and 6. Recognize and respect individual needs, such as previously assessed pains or deformities. It is your responsibility to secure the extremities, provide adequate padding and support, and have physical or mechanical help to avoid unnecessary straining of the staff and patient. Because anesthesia blocks the sensory nerve impulses, the patient will not feel pain, discomfort, or stress placed on nerves, muscles, bones, and skin. General anesthesia causes peripheral vessels to dilate. Position changes affect where the pooling of blood occurs. If the head of the OR bed is raised, the lower torso will have increased blood volume and the upper torso may become compromised. Hypovolemia and cardiovascular disease can further compromise the patient's status. Improper positioning can potentially result in muscle strain, joint damage, pressure injuries, nerve damage, and other untoward effects. Electrosurgery and smoke. Care must be taken to correctly place the grounding pad and all electrosurgical equipment to prevent injury from burns or fire. When an electrosurgical unit is in use, the patient must be properly grounded to prevent unintended injury. Excess hair, adipose tissue, bony prominences, fluid, edema, adhesive failure, and scar tissue can compromise safety. Fire in the OR can have devastating consequences for the patient. Fortunately, we can prevent surgical fires with awareness of the hazards and emphasis on safe practices. Preparing surgical site. The purpose of skin preparation, or prepping, is to reduce the number of microorganisms available to migrate to the surgical wound. The circulating nurse, surgeon, or surgical assistant completes the task of prepping before surgery. The skin is prepared by mechanically scrubbing or cleansing the surgical site with an antimicrobial agent specific to the procedure. Follow manufacturer's instructions for proper application of the prepping agent. The principle of scrubbing from the clean area, site of the incision, to the dirty area, distal to the incision, is always followed. Antiseptic agents used for skin preparation may contain alcohol and therefore are flammable. Skin injury can occur if these agents pool under the patient. Care must be taken to ensure that these agents are properly confined and allowed to fully dry. After the skin is prepped and the fumes are allowed to dispel to reduce the risk for fire, the sterile members of the surgical team drape the area. Only the site to be incised is left exposed. Safety considerations. All surgical procedures put the patient at risk for injury. These injuries include infections, physical trauma from positioning or equipment used, or physiologic effects of surgery itself. Although technical skills such as operating equipment or proper instrument handling are a critical part of ORRN competency, there is strong research supporting that non-technical skills, NTS, also have a high impact on outcomes. These include proper and clear communication, teamwork, situational awareness, e.g., anticipatory cognitive skills, and stress and fatigue management. Considering the importance of NTS skills, especially in crisis events, some agencies use special training programs to develop these skills. There are standard approaches, such as a variety of communication tools, that promote safe patient care and minimize the potential negative effects of human factors. Communication. Many team members care for the patient as they move through the perioperative continuum. Chances for error arise whenever team members share information. The Joint Commission requires that all healthcare providers use a standardized approach to handoff communication. As a RN, use SBAR to ensure that a complete and accurate handoff is done every time patient care is transferred to another provider, e.g., change of shift, surgeon to nurse, ORRN to PACU-RN. Surgical Care Improvement Project. The Surgical Care Improvement Project, SCIP, is a national quality partnership of organizations focused on improving surgical care by significantly reducing the number of complications from surgery. Specific SCIP measures include 1. A prophylactic antibiotic started within 30 to 60 minutes before the surgical incision to decrease risk for infection, 2. Applying a warming blanket to prevent unintended hypothermia, and 3. Applying intermittent pneumatic compression devices, IPCs, to minimize the risk for VTE. Timeout and surgical checklist. The National Patient Safety Goals, NPSGs, require a pre-procedure verification process. This includes verification of relevant documentation, e.g. history and physical examination, signed consent forms, nursing and pre-anesthetic assessment, and the results of any diagnostic studies, e.g. x-rays, biopsy reports. Any needed blood products, implants, devices, and special equipment must be available. The Universal Protocol, one of the NPSGs, is followed to prevent wrong site, wrong procedure, and wrong surgery. Wrong surgical procedure and surgery on the wrong body part or wrong patient are sentinel events, never events, or SREs. The AORN has a position statement about correct site surgery and guidelines for implementing the Universal Protocol. The surgeon marks the procedure site. If possible, the marking is done with the patient's involvement. A patient safety checklist for ORs is the cornerstone of a major focus to make surgery safer. Using the World Health Organization, WHO Surgical Safety Checklist has improved compliance with standards and decreased complications from surgery. In addition, OR staff complete a fire risk assessment to identify and reduce the potential for a fire. Nursing management, patient after surgery. Through constant observation of the surgical process, the ACP anticipates the end of the procedure. The ACP gives proper types and doses of anesthetic agents so that their effects will be minimal at the end of surgery. This allows greater physiologic control of the patient during the transfer to the PACU. The ACP and you or another member of the surgical team go with the patient to the PACU. The handoff, including the patient's status and the procedure done, is communicated to the nurse receiving the patient in the PACU to promote safe, ongoing care. Anesthesia. The American Society of Anesthesiologists, ASA, defines anesthesia according to the effect that it has on the patient's sensorium and pain reception. These definitions include minimal sedation, e.g., anxiolysis, moderate sedation analgesia, deep sedation analgesia, and general anesthesia. The science of providing anesthesia continues to evolve. For example, non-invasive electroencephalogram-based technology allows ACPs to track the level of patient awareness, i.e., awareness monitoring, during surgery and adjust anesthesia as needed. The anesthetic technique and agents are chosen by the ACP in collaboration with the surgeon and patient. The ACP has ultimate responsibility for the choice of anesthesia. Contributing factors include the patient's current physical and mental status, age, allergies, pain history, expertise of the ACP, and factors related to the procedure, e.g., length, site, discharge plans. An absolute contraindication to any anesthetic technique or agent is patient refusal. The ACP obtains anesthesia consent, writes orders for preoperative and postoperative drugs, and assigns the patient an anesthesia classification. The ASA physical status classification system is based on the patient's physiologic status. It uses a scale of P1 to P6. An intraoperative complication is more likely to develop with a higher classification number. Types of anesthesia techniques include moderate to deep sedation, monitored anesthesia care, general anesthesia, and local and regional anesthesia. Moderate to deep sedation. Moderate to deep sedation is used for procedures done outside of the OR, e.g., reduction of dislocated joints in the emergency department. The presence of an ACP is not needed. Trained RNs who are allowed by agency protocols and state nurse practice acts can provide this type of anesthesia. It is given by the nurse under the direct supervision of a physician. Monitored anesthesia care. Monitored anesthesia care is used for diagnostic or therapeutic procedures done in or outside of the OR, e.g., endoscopy clinic. It includes varying levels of sedation, analgesia, and anxiolysis. A critical part of MAC is the assessment and management of any physiologic problems that may develop. The provider of MAC may be an ACP since it may be necessary to change to general anesthesia during the procedure. General anesthesia. The goals of anesthesiology include the 1. Control of excessive biologic responses induced by a variety of stressors, and 2. Protection of patients from stress-induced complications. To this end, total intravenous anesthesia, TIVA, and newer inhalation agents have a fast onset, fast elimination, and fewer undesirable side effects than earlier agents. These factors promote early discharge from the PACU and ambulatory surgery centers. General anesthesia is the technique of choice for patients who are having surgical procedures that are of significant duration, need skeletal muscle relaxation, require uncomfortable operative positions because of the location of the incision site, or require control of ventilation. Other reasons include patient refusal of local or regional techniques, contraindications to other techniques, and uncooperative patients. Patients may be uncooperative due to intoxication, emotional lability, head injury, impaired cognition, or inability to remain immobile for any length of time. Phases of general anesthesia are outlined in Table 18.5. General anesthesia may be induced by IV or inhalation and maintained by either a combination of the two. A balanced technique, using adjunctive drugs to complement the induction, is the most common approach used for general anesthesia. IV agents. All routine general anesthetics begin with an IV induction agent, whether it is a hypnotic, an anxiolytic, or a dissociative agent. When used during the initial period of anesthesia, these agents induce sleep with a rapid onset of action. A single dose lasts only a few minutes. This is long enough for placement of a laryngeal mask airway (LMA) or an endotracheal ET tube. Once this is done, the ACP gives the inhalation and IV agents. Recent advances in IV hypnotics, e.g. Precedex, and opioids, e.g. Altiva, have led to the more frequent use of TIVA. However, the patient may still need advanced airway management, e.g. LMA ET tube, to receive oxygen-air mixtures. Inhalation agents. Inhalation agents are the cornerstone of general anesthesia. They may be volatile liquids or gases. Volatile liquids are given through a specially designed vaporizer after being mixed with oxygen as a carrier gas. This gas mixture is then delivered to the patient through the anesthesia circuit. Waste gases are removed using negative evacuation pressure venting to the outside of the agency. Inhalation agents enter the body through the alveoli in the lungs. Ease of administration and rapid excretion by ventilation make them desirable agents. One undesirable trait is the irritating effect some inhalation agents, e.g. desflurane, Supernal, have on the respiratory tract. Complications include coughing, laryngospasm, and increased secretions. Once the patient has been induced with an IV agent, the choice for delivering inhalation agents is usually through an ET tube or LMA. The ET tube allows control of ventilation and protects the airway from aspiration. LMAs are currently an important option for patients with difficult airways, but they do not provide access to the trachea or airway protection with the same certainty as ETs. Complications of ET tube or LMA use are primarily related to insertion and removal. These include failure to intubate, damage to teeth and lips, laryngospasm, laryngeal edema, sore throat, and hoarseness caused by injury or irritation of the vocal cords or surrounding tissues. Adjuncts to general anesthesia. General anesthesia is rarely limited to a single agent. Drugs added to an inhalation anesthetic, other than an IV induction drug, are termed adjuncts. Adjuncts are added to the anesthetic regimen to achieve unconsciousness, analgesia, amnesia, muscle relaxation, or autonomic nervous system control. They include opioids, benzodiazepines, neuromuscular blocking agents, muscle relaxants, and antiemetics. It is important to know that we often give these drugs in combination, and they may have synergistic or antagonistic effects. You may see deeper levels of sedation or more drug-related side effects beyond those seen with inhalation anesthetics alone. If needed, drugs are available to reverse the effects of some of these adjuncts. Disassociative anesthesia. Disassociative anesthesia interrupts associative brain pathways while blocking sensory pathways. The patient may appear catatonic, is amnesic, and has profound analgesia that lasts into the post-operative period. Ketamine, Ketalar, given IV or IM, is a common dissociative anesthetic. It is a potent analgesic and amnesic. Ketamine is given to asthmatic patients because it promotes bronchodilation. In trauma patients, it increases heart rate and helps maintain cardiac output. Because ketamine is a phenylcyclohexylpiperidine (PCP) derivative, the drug may cause hallucinations and nightmares, limiting its usefulness. Concurrent use of midazolam, Versed, can reduce or eliminate the hallucinations. Providing a quiet, unhurried environment in the PACU is especially important for all patients receiving dissociative anesthesia. Local and regional anesthesia. Local anesthesia interrupts the generation of nerve impulses by changing the flow of sodium into nerve cells. The result is autonomic nervous system blockade, anesthesia, and skeletal muscle flaccidity or paralysis. Local anesthetics are topical, ophthalmic, nebulized, or injected. A local anesthetic is applied to a specific area of the body by the surgeon or ACP. It does not involve sedation or loss of consciousness. Regional anesthesia, or block, using a local anesthetic, is always injected. It involves a central line, e.g., spinal, or group of nerves, e.g., plexus, that innervate a site remote to the point of injection. Administration of a local or regional anesthetic may involve a concurrent use of MAC or moderate to deep sedation, either pre-injection or intraoperatively. Regional blocks are used as preoperative analgesia during surgery to manage surgical pain and after surgery to control pain. Indwelling catheters that deliver local anesthetic to the surgical site through a pump implanted during surgery can give continuous pain relief up to 72 hours after surgery. Advantages of local and regional anesthesia include rapid recovery and discharge with continued postoperative analgesia without any accompanying cognitive dysfunction. They can be safely used in patients who have comorbidities that prevent the use of general anesthesia. Disadvantages include the potential for technical problems, discomfort at the injection site, and the inability to precisely match the agent's duration of action to the duration of the procedure. Another disadvantage is the risk for inadvertent vascular injection leading to local anesthetic systemic toxicity, LAST. LAST first presents as confusion, metallic taste, oral numbness, and dizziness. Without treatment, seizures, coma, and dysrhythmias may occur. The topical applications of creams, ointments, aerosols, and liquids are standard methods to administer local anesthesia. The drug is applied directly to the skin, mucous membranes, or open surface. Eutectic mixture of local anesthetics, EMLA cream, a combination of prilocaine and lidocaine, is an example. It is applied to the site 30 to 60 minutes before a procedure. The success of injected local anesthetics may be limited by prolonged duration of procedure or infection at the injection site that interferes with drug absorption. In ambulatory or outpatient procedures, you may aid the ACP in administering a peripheral or regional block. You must be familiar with the drugs, including the methods of administration and adverse and toxic effects. Initial assessment of the patient should include the patient's history with the use of local anesthetics and any adverse events associated with their use by the patient or blood relatives. Many patients report allergies to local anesthetics. Although true allergies to local anesthetics occur, they are rare. Allergies are likely to be a result of additives or preservatives in the preparation. Some local anesthetics are combined with epinephrine to provide localized vasoconstriction. This decreases absorption and extends the action of the agent. However, if the local anesthetic is absorbed in the tissues or inadvertently injected IV and enters the general circulation, the patient may have tachycardia, hypertension, and a general feeling of panic. Examples of common regional nerve blocks include brachial plexus blocks, IV regional anesthesia, IVRA, or Bayer block anesthesia, and femoral, axillary, cervical, sciatic, ankle, and retrobulbar blocks. For IVRA or Bayer block, the patient has a double cuff tourniquet applied as a safety measure. You can promote the success of regional anesthesia by properly positioning the patient, monitoring vital signs during block delivery, applying oxygen therapy, and using supporting devices at the direction of the ACP that contribute to the anesthesia, e.g., ultrasound imaging, nerve stimulator, tourniquets. When a patient is receiving regional anesthesia, airway equipment, emergency drugs, and a cardiac monitor defibrillator should be available to provide advanced airway and cardiopulmonary support if needed. Spinal and epidural anesthesia. Spinal anesthesia and epidural anesthesia are also types of regional anesthesia. Spinal anesthesia involves the injection of a local anesthetic into the cerebrospinal fluid in the subarachnoid space, usually below the level of L2. The local anesthetic mixes with cerebrospinal fluid. Depending on the extent of its spread, various levels of anesthesia are achieved. Because the local anesthetic is given directly into the cerebrospinal fluid, a spinal anesthetic produces an autonomic, sensory, and motor blockade. Patients develop vasodilation and may become hypotensive from the autonomic block. They feel no pain because of the sensory block. They cannot move because of the motor block. The duration of action of the spinal anesthetic depends on the drug used and the dose given. A spinal anesthetic may be used for procedures involving the extremities, e.g., joint replacements, and lower gastrointestinal, prostate, and gynecologic surgeries. An epidural block involves injection of a local anesthetic into the epidural space via a thoracic or lumbar approach. The anesthetic agent does not enter the cerebrospinal fluid, but binds to nerve roots as they enter and exit the spinal cord. With the use of a low concentration of local anesthetic, sensory pathways are blocked but motor fibers are still intact. In higher doses, sensory and motor fibers are blocked. Epidural anesthesia may be the sole anesthetic for a surgical procedure. In addition, a catheter may be placed to allow for intraoperative use and continued analgesia in the postoperative period. For postoperative analgesia, lower doses of epidural local anesthetic, usually in combination with an opioid, are used. Epidural anesthesia is often used for analgesia or in combination with MAC or general anesthesia in obstetrics, vascular procedures involving the lower extremities, lung resections, and renal and mid-abdominal surgeries. The desirable effects of vasodilation and analgesia contribute to better surgical outcomes. With spinal or epidural anesthesia, the patient can stay fully conscious, receive MAC, or choose general anesthesia. The onset of spinal anesthesia is more rapid than that of epidural anesthesia. Both may be extended in duration using indwelling catheters, thus allowing for more doses of anesthetic. With either anesthesia, closely observe the patient for manifestations of autonomic nervous system blockade. These include hypotension, bradycardia, nausea, and vomiting. There is less autonomic nervous system blockade with epidural anesthesia than with spinal anesthesia. Should too high a block be present, the patient may have tingling in the arms and hands or inadequate breathing and apnea. Other complications include post-dural puncture, headache, back pain, isolated nerve injury, and meningitis. Gerontologic considerations. Patient during surgery. Although anesthetic agents have become safer and more predictable, the aging process affects the absorption, distribution, and metabolism of drugs. This results in changes in their onset, peak, and duration, independent of the route of administration. Because of this, anesthetic drugs need to be carefully titrated when given to older adults. Physiologic changes in aging may also change the patient's response to blood and fluid loss and replacement, hypothermia, pain, and tolerance of the procedure and positioning. Carefully monitor the older adult's response to all anesthetic agents. Postoperative delirium is a common complication in this population and associated with adverse surgical outcomes. Assess the postoperative recovery from anesthesia before the patient is transferred out of the PACU. Some older adults may have a hard time communicating and following directions because of problems with hearing or vision. These factors increase the need for clear and concise communication in the OR, especially when preoperative sedation is combined with already existing sensory deficits. Because of decreased ability to perceive discomfort or pressure on vulnerable areas and a loss of skin elasticity, the older adult's skin is at risk for injury from tape, electrodes, warming and cooling blankets, and certain types of dressings. Pooling of solutions used to prepare the skin in dependent areas can quickly create skin burns or abrasions. Care and vigilance are needed in preparing and positioning the older patient. The older adult often has osteoporosis and/or osteoarthritis. Misalignment, pressure, or other insults to arthritic joints, desensitized from an anesthetic, may create long-term injury and disability. Older adults are at a greater risk for perioperative hypothermia. Consider using warming devices and carefully monitor them when used. Perioperative crisis events. Although the incidence of crisis events has significantly decreased with scientific advancements, there is an inherent risk with surgery for an adverse outcome, which may be of critical nature. Some events may be expected, e.g., cardiac arrest in an unstable patient, massive blood loss during trauma surgery. Others may occur without warning, e.g., air embolism, hypoxia, demanding immediate intervention by all members of the OR team. More rare events include anaphylactic reactions and malignant hyperthermia. Anaphylactic reactions. Anaphylaxis is the most severe form of an allergic reaction, manifesting with life-threatening pulmonary and circulatory complications. ACPs give patients a variety of drugs, including anesthetics, antibiotics, and blood products. Anesthetic agents, antibiotics, and latex cause many allergic reactions. Vigilance and rapid intervention are essential. Anesthesia may mask the initial manifestations of anaphylaxis. An anaphylactic reaction causes hypotension, tachycardia, bronchospasm, and pulmonary edema. Anaphylaxis is discussed in Chapter 13. Latex allergy has become a concern in the surgical setting. Gloves, catheters, and many devices contain natural rubber latex. Latex allergy protocols should be set up in each agency to provide a latex-safe environment for susceptible patients. Latex allergies are discussed in Chapter 13. Malignant hyperthermia. Malignant hyperthermia, MH, is a rare disorder characterized by hyperthermia with skeletal muscle rigidity. It can result in death. MH occurs in susceptible people when they are exposed to certain anesthetic agents. Succinylcholine, anectine, especially when given with volatile inhalation agents, is the primary trigger of MH. Other factors include stress, trauma, and heat. When MH does occur, it is usually during general anesthesia. It may occur in the recovery period too. MH is an autosomal dominant trait. It is variable in its genetic manifestation, so predictions based on family history are important but not reliable. The fundamental defect is hypermetabolism of skeletal muscle resulting from altered control of intracellular calcium. This leads to muscle contracture, hyperthermia, hypoxemia, lactic acidosis, and hemodynamic and cardiac problems. Tachycardia, tachypnea, hypercarbia, and ventricular dysrhythmias may occur but are nonspecific to MH. MH is diagnosed after ruling out other causes of the hypermetabolism. The rise in body temperature is not an early sign of MH. Unless promptly detected and treated, MH can result in cardiac arrest and death. The definitive treatment of MH is prompt administration of dantrolene, Dantrium, Rhinodex. Dantrolene slows metabolism, reduces muscle contraction, and mediates the catabolic processes associated with MH. To prevent MH, take a careful family history and be alert to the development of MH perioperatively. The patient known or suspected to be at risk for this disorder can receive anesthesia with minimal risks if proper precautions are taken. Patients with MH need to be aware of the condition so that family members may be genetically tested.